Okay, so if you have a pet, a dog or a cat, you've probably been there. The scratching, the licking, maybe little bumps, crusty spots. It's super common.
Oh, absolutely. And so frustrating for everyone involved.
Totally. And sometimes, you try the usual stuff. Maybe the vet gives you an antibiotic, but it doesn't clear up. Or maybe it looks better for a bit and then...
It comes right back as soon as the medication stops.
Exactly. That's the kind of situation we're getting into today.
Right. We're doing a deep dive into a particular challenge, methicillin-resistant pyoderma, or MRP, in dogs and cats.
So this isn't just like a standard hotspot or a simple itch.
No, not at all.
This is when those skin infections, the common ones, involve bacteria that have, well, figured out how to ignore the antibiotics we normally use.
And to really understand this, we've been digging into the source material, the detailed professional resources, the kind of stuff vets consult for these complex cases.
Yeah, we're sort of looking at the veterinary playbook here.
Pretty much. Pulling back the curtain a bit.
So our goal today is pretty straightforward.
Mm-hmm.
We want to cut through the jargon, pull out the really crucial facts you need to know, understand why this is a big deal, even if it looks like any other skin infection, and basically map out the approach. How vets figure it out, and crucially, how they manage it.
What is it? Why is it resistant? How do you spot it? What's the plan?
Exactly.
It definitely takes more detective work than your average skin infection, but knowing the key pieces, well, that makes tackling it achievable.
Okay, let's dive in then. Methicillin-resistant pyoderma. At its core, what is it? Which bacteria are we usually talking about here?
And what does that methicillin-resistant part really mean for treatment?
Right.
So fundamentally, MRP is a bacterial skin infection, usually caused by staphylococcal bacteria. In dogs, the most common culprit is Staphylococcus pseudintermedius.
Okay.
Sometimes, though less often, it could be Staphylococcus aureus. That's the one people might know more from human medicine. But the key part, like the name says, is the resistance. These specific staph bacteria, they've developed resistance not just to methicillin itself, but actually to a whole group of really common antibiotics.
A whole group? Like which ones?
The beta-lactams.
Beta-lactams. So like the standard antibiotics, the go-tos.
Precisely. Penicillins, amoxicillin, lots of cephalosporins. These are often the first thing a vet reaches for with a skin infection.
Yeah.
So if the infection is caused by staph that's resistant to this whole class, well, those standard treatments just aren't going to work.
So if your vet prescribes one of those, and it is this resistant MRP, you're basically using the wrong key for the lock.
That's a perfect analogy, yeah. And the sources we looked at, they really hammer home that this resistance is strongly linked to previous antibiotic use.
Ah, okay. Now that's interesting and maybe a bit worrying. So using antibiotics in the past can actually set up this problem for later. How does that happen?
Well, think about it like natural selection, really. In any big population of bacteria, you might have a tiny number that are naturally resistant to a certain drug, just by chance.
Okay.
Now, you treat an infection with that antibiotic, it wipes out all the susceptible bacteria, the ones it can kill.
Right.
But those few resistant ones, they survive. And now they've got no competition for resources, so they multiply.
Ah, so they take over.
Exactly. Each time you expose bacteria to an antibiotic, you're essentially selecting for the resistant ones. You're giving them the advantage. Over time, especially with repeated exposure, you can end up with a bacterial population that's mostly resistant.
Wow.
Yeah.
Okay, so it's not like the antibiotic magically creates resistance, but it clears the way for the resistant ones that were already there, maybe in tiny numbers, to flourish.
Precisely. It highlights just how important it is to use antibiotics, judiciously, only when necessary and using the right ones.
Definitely. A classic example of selection pressure. Okay, so we know what MRP is. Staph infection. Resistant to common beta-lactam antibiotics, often because of past antibiotic use. Who usually gets this? Is it random, or are certain pets more likely?
Good question. While technically any dog or cat could get MRP, the resources really emphasize that it's much more common in pets that already have some kind of underlying skin issue.
Ah, something that makes them prone to skin infections in the first place.
Exactly, especially pets with chronic, recurring skin problems.
Like maybe pets with allergies?
Allergies are a huge one. Flea allergies, environmental allergies, copy food allergies. All these disrupt the skin barrier. They damage that first-line defense.
Makes the skin vulnerable.
Right.
Oh, yeah.
Creates an environment where bacteria can easily set up shop. Parasites, too, like Demodex mites, can weaken the skin's defenses.
Okay.
And even things like hormonal problems. Endocrine diseases, hypothyroidism, Cushing's disease, they can affect skin health and the immune system, making infections more likely to happen and harder to clear.
So it's often not just MRP appearing out of the blue.
Yeah.
It's usually layered on top of something else.
That's a very common scenario, yes. Other things too, anything damaging the skin barrier or messing with the immune system, like long-term steroid use can suppress immunity.
Right.
Even things like deep skin folds in certain breeds, they trap moisture and bacteria, or sometimes young animals with immune systems that aren't fully developed yet.
Got it. So the defenses are down, bacteria move in, and if those bacteria happen to be resistant or become resistant through selection, boom, you've got MRP.
That's the picture.
Now, you said the clinical signs, the bumps, pustules, crust, they look just like regular pyoderma. So
Yeah.
how do you possibly tell the difference just by looking?
You can't. And that's a really critical point the sources make. Visually resistant and sensitive staph infections can look identical.
That must be incredibly confusing for owners. They're seeing the same old symptoms.
It absolutely is. The big clue, the thing that really makes a vet suspect MRP, is treatment failure. When a pet has classic signs of a bacterial skin infection, they get treated with an antibiotic that should work against typical staph. But they don't get better.
Or they get worse.
Or they get worse, or new spots pop up while they're still on the antibiotic. That's a huge red flag. Or maybe they seem to clear up, but the infection comes roaring back almost immediately after the drugs stop.
Okay, so suspicion arises mainly when the standard approach fails.
Mm-hmm.
How do you go from, this isn't working, to actually confirming it's MRP and, maybe more importantly, finding out what will work?
This is where one specific test becomes absolutely crucial, non-negotiable, according to the resources we reviewed.
Okay.
While you might do initial tests like skin scrapes to check for mites, or cytology looking at cells and bacteria under the microscope, the essential tool for suspected MRP is a bacterial culture and sensitivity test, CNS.
Culture and sensitivity, right, I've heard of that. Break it down for us. What does that involve?
It's a two-step process, usually done by an outside lab. First, your vet collects a sample of the bacteria from the infected skin. Could be a swab, maybe pressing sterile tape to the lesion, or sometimes even a tiny skin biopsy if the infection seems deep.
Okay, get the sample.
Send it to the lab. Step 1 is the culture. They grow the bacteria on special plates to get enough of it, and then they identify exactly what species it is like. Yes, this is Staphylococcus pseudointermedius.
Identifying the enemy.
Exactly. Then step 2 is the sensitivity testing. They take those bacteria they've grown and expose them to a whole panel of different antibiotics right there in the lab.
See what kills them.
Precisely. They see which antibiotics stop the bacteria from growing or kill them, and which ones the bacteria just laugh off.
So the culture tells you who you're fighting, and the sensitivity tells you what weapons actually work against that specific bug in that specific pet.
You got it. It gives you the bug's ID and its specific weaknesses, and the sources are crystal clear. Without a CNS, you are essentially guessing when you suspect MRP.
Flying blind.
Completely. You don't know for sure it's resistant, and you definitely don't know which antibiotics, if any of the common ones, might still have a chance, or which less common ones you need to use. Guessing just leads to more treatment failure and potentially worsens the resistance problem.
That makes total sense.
Mm-hmm.
So culture and sensitivity is the absolute key for diagnosis and guiding treatment. Are there other diagnostic steps, maybe looking for that underlying cause you mentioned?
Oh, absolutely. And that ties right back into why the pet got infected in the first place. If allergies are high on the list, the workup might involve things like skin testing or maybe an elimination diet trial for food allergies.
Trying to find a trigger.
Right. If there's suspicion of a hormonal issue like hypothyroidism or Cushing's, then blood tests to check those hormone levels are needed. Sometimes general blood work might show signs of inflammation, especially if the infection is deep, but it won't diagnose the MRP itself.
Okay.
Skin biopsies are usually kept for more unusual cases, really deep infections, or if the vet needs to rule out other skin diseases that might look similar.
So it's like a two-pronged diagnostic strategy. Use the CNS to nail down the resistant bug and its weaknesses, and then investigate to find the reason the pet was vulnerable to infection to begin with.
Exactly right. Both are absolutely vital for managing this long term. Treating the current infection is step 1, but stopping it from coming back means fixing the underlying issue.
Okay, makes sense. So let's say MRP is confirmed. You've got that CNS report back. The usual suspects, the beta-lactams, are off the table.
Mm-hmm.
What's left? How do you actually treat this thing?
The treatment plan has to be guided strictly by those sensitivity results. Rule number 1. You only use systemic antibiotics pills or injections that the lab report specifically says the bacteria are susceptible to.
No exceptions.
No exceptions based on guesswork.
Are there certain types of antibiotics that tend to pop up more often as being effective against these resistant staph?
It really varies. It depends entirely on the specific bacteria from that pet and its resistance patterns. But, you might see drugs like chloramphenicol listed as sensitive, maybe clindamycin, doxycycline, or minocycline.
Hmm.
Sometimes certain fluoroquinolones, which are another class of potent antibiotics, maybe rifampin, maybe certain aminoglycosides in specific situations. But the key isn't to memorize a list, it's to look at the report for that individual case.
Right. Use the data you paid for. What about treating the skin itself? Topical stuff.
Topical therapy, absolutely critical. The sources stress this isn't just a side thing, it's a cornerstone of treatment.
Really? More than just supportive.
Definitely. For all cases of MRP, even if the pet is on systemic antibiotics, they need frequent, rigorous topical treatment too. In fact, for some infections that are more localized or maybe milder, really intensive topical therapy alone might be enough to clear it.
Wow, so you might even avoid oral antibiotics sometimes.
Potentially, yes, if the situation is right and the topical approach is aggressive enough. We're talking about things like medicated shampoos, sprays, often containing antiseptics like chlorhexidine, maybe benzoyl peroxide. Even dilute bleach baths can be surprisingly effective. For very small specific spots, an ointment called mupirocin can be very good. The idea is to directly attack and reduce the bacterial numbers on the skin surface.
Something the pills can't do quite as directly.
Exactly. Systemic antibiotics work from the inside out. Topicals work from the outside in.
So it's often a combined arms approach.
Mm-hmm.
Targeted internal meds based on the CNS, plus hitting the skin directly with washes, sprays, whatever works topically.
That's the gold standard approach for many, many cases. Now, if it's a really severe, widespread, or deep infection, sometimes hospitalization is needed.
Okay.
For IV fluids, maybe stronger IV antibiotics initially, and really intensive topical care like soaking or whirlpool baths. The severity really dictates how aggressive you need to be.
Gotcha. Now, earlier we talked about underlying conditions like allergies, sometimes needing meds like steroids, prednisone, for example. If a pet has MRP and is on steroids for that underlying issue, what happens there? Should they keep taking the steroids?
That's a tricky balance. Generally, the advice from the sources is to try and stop or at least significantly reduce the corticosteroid dose while actively treating the MRP infection.
Why is that?
Because steroids suppress the immune system, and you really need the pet's own immune system firing on all cylinders to help fight off that bacterial infection.
Right, you don't want to hinder the body's own defenses.
Exactly. Plus, steroids can sometimes mask the signs of infection, making it harder to judge if the antibiotic is actually working effectively. Now, if the underlying disease is so severe that some steroid use is absolutely unavoidable,
Then what?
then the antibiotic course might need to be longer, and monitoring becomes even more critical to make sure the infection is genuinely clearing.
Okay, makes sense. Avoid them if possible during MRP treatment.
Well,
What about the antibiotics themselves? Since these aren't always the standard first-line drugs, are there particular side effects or precautions to be aware of?
yes, absolutely. Every drug has potential side effects. Some of these antibiotics used for MRP can cause stomach upset, vomiting, diarrhea.
Common one.
Right. Others carry more specific risks. Aminoglycosides, for instance, can potentially harm the kidneys, especially with long use or in pets that already have kidney problems.
He's careful monitoring then.
Definitely. Trimethoprim sulfa combinations, another option, can have various potential issues if used long-term. Chloramphenicol, while often effective, needs careful handling by people giving it due to a rare but serious risk to human bone marrow.
Wow.
And it can cause dose-related side effects in pets too, especially cats. So yes, the vet will choose based on sensitivity, but also weigh the potential risks and discuss monitoring.
So it's not just will it kill the bug,
Yeah.
but also is it safe for this pet and what do we need to watch for?
Exactly. It's a benefit versus risk calculation, always.
Okay. And what about how long treatment takes?
Yeah.
And the overall outlook? Is this harder to cure?
Duration. Patience is key here. And sticking to the plan religiously. Antibiotics are usually given for at least 7 to 10 days after the infection looks completely gone.
After, not just until it looks clear.
Correct. Beyond clinical cure. So for a superficial infection, that might mean a total of 3 or 4 weeks of antibiotics. But if it's a deep infection, like down into the hair follicles, furunculosis treatment could easily be 6 weeks, 8 weeks, 10 weeks, sometimes even longer.
That's a serious commitment.
It is. And regular recheck appointments while they're still on meds are vital to make sure things are progressing and catch any problems early.
And the prognosis. Can you generally cure MRP?
The outlook for clearing the acute infection is generally good, but it hinges on two absolutely critical things.
Okay, what are they?
One, the antibiotic choice must be based on that culture and sensitivity report. No guessing.
Right, data-driven.
And two, and this is arguably the most important factor for long-term success and stopping it from coming back, the underlying reason for the pyoderma has to be found and managed effectively.
Back to the root cause.
Yeah.
So you can kill the resistant bugs this time, but if you don't fix whatever weakened the skin's defenses,
You're just setting the stage for another infection down the road. And maybe next time it's resistant to even more drugs.
that makes sense. The MRP bacteria themselves, are they actually nastier or more dangerous than regular staph?
Not necessarily more virulent, no. They don't inherently cause worse disease. The problem is that our treatment options are so much more limited because they resist the common, often safer antibiotics. Our toolbox is smaller.
Okay, so the challenge is the resistance, not necessarily the bug itself being more aggressive.
Exactly. If you clear the infection but don't manage the allergy or the hormone imbalance or whatever it was, that skin barrier stays weak. Bacteria, including any resistant ones still hanging around on the skin, will likely multiply again.
Leading to relapse. It sounds like the real battle has two fronts: choosing the right weapon for this infection and fixing the underlying vulnerability for the future.
That sums it up perfectly. Preventing it from coming back relies almost entirely on managing that underlying condition and often using ongoing topical therapy like medicated baths to keep bacterial numbers down.
This has been really, really helpful. It's so clear that MRP, while it might look like a familiar problem, it's really a distinct challenge. It needs a totally different approach compared to a standard skin infection.
Right. It's bacterial pyoderma, usually staph, resistant to that key beta-lactam class of antibiotics, and yeah, often linked to having had antibiotics before.
The core issue isn't necessarily a superbug in terms of virulence.
No, it's that our standard arsenal doesn't work against it.
So if we had to boil it down, what are the absolute two most critical takeaways for anyone dealing with this or just trying to understand it?
Okay, number one, without a doubt, culture and sensitivity testing. It's not optional, it's fundamental. You cannot treat MRP effectively without knowing precisely which antibiotics will work for that specific case.
Essential. Got it. And the second one?
Second key point. Long-term success is impossible unless you identify and manage the underlying condition, the allergy, the hormone issue, the parasites, whatever it is that made the pet susceptible in the first place.
Yeah.
You have to address the root cause.
Fix the environment
Sure.
to prevent the problem from just cropping up again.
Exactly.
It definitely sounds like it requires more diagnostic effort, more detective work, and it limits your treatment choices. But it sounds like with those key steps, that CNS test, tackling the underlying problem, it is manageable.
It's certainly a challenge, but yeah, veterinary medicine has clear strategies to address it effectively as long as those crucial steps are followed.
It really makes you think, doesn't it?
Yeah.
How a pet's history, especially something like past antibiotic use, can literally shape the bacteria living on their skin and profoundly impact how we can treat them later on. What does this whole situation with MRP really tell us about how interconnected everything is: a pet's health history, their current state, their ability to fight off future problems? It's not just about treating today's symptoms, is it? It's about understanding that whole biological narrative.